Good morning or good afternoon, everyone. Welcome and thank you for joining us today for the webinar entitled Preventing Cisplatin-Induced Ototoxicity in Pediatrics, What You Need to Know to Improve Patient Outcomes. The program today is being hosted by Med Safety Board, or MSB, which is a subsidiary of the Institute for Safe Medication Practices. My name is Becky Lamas. I'm the manager of MSB, and I'll be moderating today's educational program, which is being sponsored by Fennec Pharmaceuticals. Next slide. So first, for those who may not be familiar with Med Safety Board, MSB is a subsidiary of the Institute for Safe Medication Practices, or ISMP, and we work directly with pharmaceutical and medical device companies to provide various safety solutions to help enhance the safe use of their products. And for those who may not be familiar with ISMP, or the Institute for Safe Medication Practices, we are the only nonprofit organization devoted entirely to preventing medication errors. And during our more than 25-year history, we've been dedicated to educating the healthcare community about safe medication practices. Next slide. The cisplatin is a commonly used chemotherapeutic agent for the treatment of certain childhood cancers. However, as it's a known ototoxic agent, patients can risk permanent bilateral hearing loss due to cisplatin use. With pediatric patients, especially younger children, at an increased risk for severe ototoxic effects. Hearing loss in this patient population can lead to delays in speech and language development and can also have a detrimental psychosocial and quality of life impact on those patients. During today's educational session, the learning objectives that will be covered by today's expert faculty include understanding the incidence and mechanism of cisplatin-induced ototoxicity in children, discussing the mechanism of action and safety and efficacy data of sodium thiosulfate in the prevention of cisplatin-induced ototoxicity. And we'll also be describing the safety impact of select inactive ingredients in pharmaceutical products in pediatric patients. So some quick housekeeping items before we start. The program is being recorded and it'll be available later on the MSB website. www.medsafetyboard.com or .org. It is .com. Handouts for today's program can be found in the Zoom chat box and will also be available again on the MSB website. All attendees are in listen mode only during the presentation, but feel free to ask a question by accessing the Q&A functionality on your toolbar. We'll certainly have some time at the end to answer any questions that you may have. Next slide. So before we start, I'd like to introduce our two speakers. Our first speaker is Dr. Noah Federman. Dr. Federman is a renowned pediatric oncologist, professor of pediatrics and orthopedic surgery at University of California, Los Angeles. He is the medical director of the UCLA Clinical and Translational Research Center, the director of the Pediatric Bone and Soft Tissue Sarcoma Program at UCLA, and Glaser Family Endowed Chair of Pediatric Sarcomas at UCLA. In addition, he is the program director of the California Institute of Regenerative Medicine, UCLA Health Alpha Clinic. And clinically, Dr. Federman focuses on treating children, adolescents, and young adults with localized and advanced stage solid tumors. Our second speaker for today's program is Dr. Rita Ju. Dr. Ju is the president of the Institute for Safe Medication Practices, where she provides leadership in advocacy of ISMP's mission and vision to stakeholders and develops and implements strategic goals. Prior to joining ISMP, Dr. Ju held various leadership positions throughout her 25+ year tenure in hospital pharmacies, including Director of Pharmacy at UCSF Health, Executive Director of Pharmacy and Clinical Nutrition Services at Chalk Children's, and Clinical Manager at Children's Hospital Philadelphia. Dr. Ju has presented and published extensively on clinical topics, including pediatrics, extemporaneous compounding, vaccines, healthcare technology and automation, as well as various topics on pharmacy operations and medication safety. And now I'll turn it over to Dr. Federman.
Hi, thank you all. Thanks, Becky, for the introduction. It is an honor to present to all of you here and a privilege to be on this panel alongside Rita Ju, who's truly a giant in the field of pediatric pharmacy and pharmaceutical in general. So we're going to talk about prevention of cisplatin-induced ototoxicity, and I'll be directly advancing the slide. So next slide. These are my disclosures. I think importantly, though, for the purpose of this presentation, I will be speaking about my opinions and presenting data while I have been sponsored by Fennec in the past for honoraria for speaking. Next slide. So let's talk about cisplatin first before we talk about cisplatin toxicities. I think like all great discoveries in science and medicine, they happen serendipitously, just like gravity and the discovery of penicillin. Cisplatin was truly an accidental discovery. And this is a discovery that dates back at least 70 years ago by a PhD, a biophysicist out of Michigan State, Barnett Rosenberg, who was looking at blocking cell division using electrical currents. And what he found was that indeed these electrical currents seemed to block cell division, but he couldn't quite figure it out. And it turns out it wasn't the electrical currents themselves, but the coating of the electrodes that were in the solution. And that coating consisted of cisplatin or platinum compound metal. And so how does cisplatin work in terms of being a cytotoxic? Well, it crosses the cell membrane where it goes through a process of equation, becoming either monoequated or diequated, as you'll see on the right side here. And in this process becomes a very highly reactive alkylating agent that then covalently binds to DNA and either causes intrastrand adducts or intrastrand covalent cross-linking DNA strands. Next slide. So with that, the FDA approved cisplatin nearly 50 years ago in 1978 for the treatment of testicular cancers. And since then, it has become a cornerstone therapy frontline for many solid tumors in children and adults. In pediatric oncology, we use cisplatin basically like water, frontline for germ cell tumor treatment, hepatoblastoma, medulloblastoma, neuroblastoma, and osteosarcoma, some of the more common solid tumors that we see in pediatric malignancies. And we estimate that at least 2,000 children are treated with cisplatin in our country every year. And amongst these patients that receive cisplatin, they have an exceptional survival, with at least 70 to 75% of patients going on to be long-term survivors. Next slide. But with cisplatin comes real significant toxicities, and those toxicities are both acute and lifelong chronic. They consist of things like nausea emesis, which is very common with cisplatin-containing regimens. These are highly emetogenic regimens. Or neurotoxicity, which is more common in the older patients. Nephrotoxicity, which is common at all ages, seems to worsen with age and with declining renal function. Myelosuppression, we see at all ages. And ototoxicity that we'll talk about in the next few slides. Next slide. So we know that cisplatin treatment is associated with ototoxicity in children and adults. And this is irreversible, bilateral, and progressive hearing loss. We also know that there's a dose-limiting effect of this ototoxicity in that we cannot continue to give cisplatin in the face of severe hearing loss. So oftentimes we're reducing the dose of an effective chemo agent, being cisplatin, because of severe ototoxicity associated with it. We know that there are other factors that increase the risk of hearing loss following cisplatin treatment, and those include patients that are younger in age, prior treatment with radiotherapy, and generally we're talking about CNS radiotherapy, a larger amount of cisplatin that's infused per dose, and larger cumulative dosing of cisplatin over the course of a chemotherapy protocol. In terms of our patients, our children that receive cisplatin, permanent hearing loss is very common, and it is the true majority of patients that exhibit some amount of hearing loss, with at least 60 to 70% of patients with permanent hearing loss. Next slide. So what are the mechanisms of cisplatin-induced ototoxicity? I think there are several folds. On the right side here is the anatomy of the ear, and we're talking about toxicity that can occur primarily in the inner ear, but also in the middle ear as well. We know that treatment with cisplatin causes toxic levels of reactive oxygen species that's produced in the cochlea. And these reactive oxygen species destroy cochlear hair cells, damage the stria vascularis and the spiral ganglion cells, and these are vital to hearing. Damage then begins at the base of the cochlea. Additional drug exposure with cisplatin causes damage and spread towards the cochlear apex. And these cochlear hair cells that are damaged cannot regenerate. So this is irreversible. This is permanent hearing loss. Next slide. So another question to ask as well, what is the clinical impact of this cisplatin-induced ototoxicity? We'll talk about that in the next few slides. So next slide. And I think it's important to note that acquired hearing loss, whether it's from cisplatin or otherwise, has profound, multifaceted long-term impact on children and adults. And that includes things like speech impairment, social isolation, behavioral problems, impaired learning, excess medical visits, and leading to things like career limitations. And you'll see here on the right side of the slide that impact that goes from young prelingual children into delays in development and speech comprehension, into school-age children, now impacting their academic performance, social and emotional interactions and development, leading to potentially poor self-esteem. And that further goes into the development continuum into teenagers and young adults. Again, more impact on academic performance, relationship development, marriage, employment potential, and the ability to truly live independently. And you'll see along with that, not just the limitations in activities of daily living and academic performance and employment, but what goes along with that is increasing anxiety, increasing depression, and social isolation. So for any parent that's dealing with a child with severe hearing loss, whether it's from cisplatin or otherwise, you're looking at a lifelong of potential problems that build up from the time of infancy through adulthood. Next slide. When we talk about cisplatin-induced ototoxicity specifically, what are the symptoms? First and foremost, it's bilateral irreversible hearing loss. Usually it's symmetric, so we're seeing it in both ears at the same time, at the same amounts, and it's progressive over the time of receiving cisplatin and then beyond. We see patients with tinnitus. Generally, they describe that as a persistent ringing in their ears or a persistent static or buzzing. This in of itself is a symptom that causes real problems because there is no treatment for it. And patients can also have vertigo, meaning a loss of or that sense of that the room is spinning, and it can also have persistent sort of nausea and instability. We see hearing loss that affects higher frequencies first and then progresses to involve lower frequencies. And why that's important is that the lower frequencies are usually associated with speech. We also see that hearing can be affected, and that's been my personal experience from that very first exposure, that first treatment with cisplatin. So one dose, 1 day of cisplatin can result in significant ototoxicity. We also see cisplatin can persist in the cochlea for months and years, and it can further exacerbate deterioration. On the right side of the slide is a graphic showing one patient receiving cisplatin in a case study. And what you'll see here is what you'll see from 4 cycles of cisplatin, one treatment of cisplatin already, you can see reduction in hearing loss. And as you get to the 4th cycle on the right side of that figure, you'll see significant amount of hearing loss. So, mild hearing in the beginning from losing conversation with background noise to all of a sudden losing normal conversation, and then basically not even being able to hear a lawnmower by the end of the 4th cycle. Next slide. So I think the recommended interventions that, prior to prevention of hearing loss for childhood cancer survivors really varied by degree of hearing loss. Again, most of our patients treated with cisplatin go on to be long-term survivors, and that is fantastic. It's been one of the great contributions of our pediatric oncology groups, our collaborative groups in clinical trials, is really improving the outcomes, the survival outcomes for these patients to now kind of almost 80% across all cancers and all ages in pediatrics. However, for these patients, because the majority of them are long-term survivors, they're dealing with the late effects, the long-term effects of permanent hearing loss. So what do we do for these patients in practice? Almost all of my patients that have received cisplatin are referred to an audiologist, not just for testing and monitoring during treatment, but lifelong after treatment. I am very heavily counseling patients and their families prior to receiving cisplatin about what to expect, that we do expect that they will have hearing loss, and we do expect that it will be significant and will be permanent. And we discuss what that looks like, that many of our patients receiving this will require, and if not most of them, will require hearing aids, and that is permanent. We talk about communication strategies, compensation that people can use. I will tell you that during the pandemic, with everyone wearing masks, it really affected our patients who do use a combination of lip reading to help them fill in gaps, and that was very difficult with patients and caregivers masking. Speech and language therapy is very important, especially for the infants and toddlers that are receiving cisplatin, that will, you want to make sure they're developing their language and not falling behind, and certainly, and doing so with an occupational therapist and a speech and language therapist. And then we want to make sure as they reintegrate in school that there are accommodation and support at schools and in the workplace as they get older for significant hearing loss. Here are some things below that are used in terms of remote microphones, personal hearing aids, and potentially for those patients with truly severe hearing loss that may go on to receive a cochlear implant. Next slide. So I think the holy grail here is not to have to do any of those things on the prior slide, but really to prevent cisplatin-induced ototoxicity. And how do we do that? We're now going to review the clinical data that resulted in the first and only FDA-approved a medication for this, being sodium thiosulfate, or PEDMARK. We will look at the mechanism of action of PEDMARK and clinical trial data, including efficacy and safety. Next slide. So PEDMARK, or sodium thiosulfate anhydrous, can protect hearing by reducing risk of ototoxicity from cisplatin. And so how does this actually work? PEDMARK increases levels of endogenous antioxidants. It scavenges reactive oxygen species. And we believe that some of the prevention of toxicity here results in direct interaction between cisplatin and the thiol group in STS that binds the cisplatin in the inner ear. We know PEDMARK can enter cells at least partially through a sodium sulfate cotransporter and then causes intracellular effects, including increasing antioxidant glutathione and inhibiting intracellular oxidative stress. And we also know that in PEDMARK, there is no potassium chloride and there's minimal boric acid in the excipients. So you're not giving these potentially toxic agents to patients along with. Next slide. So here are the two you can go back to that. Yep, here are the two landmark clinical trials that were done nationally and internationally that resulted in the first and only approved sodium thiosulfate formulation in preventing cisplatin-induced ototoxicity. There was a New England Journal of Medicine article that you'll see here on the left side, which was the PSYOP clinical trial, and this Lancet Oncology publication from the Children's Oncology Group North American trial ACCL 0431. We're going to look at both of these trials in detail because these two trials resulted in the seminal approval of PEDMARK to reduce risk of ototoxicity associated with cisplatin in children with localized non-metastatic solid tumors. And this was FDA approved in September of 2022, so relatively recently. Next slide. This is the SIOPOL 6 multi-center randomized controlled open label study. This was conducted by the International Childhood Liver Tumor Strategy Group from 2007 to 2018, so over a decade of data. And this was led by Dr. Pepe Brock. So this was the SIOPOL 6 design. These were 114 patients. They were children from 1 month to 18 years old, randomized 1-to-1 to receive cisplatin or cisplatin plus PEDMARK for standard risk hepatoblastoma. So these were all hepatoblastoma patients. And the major efficacy outcome measure here was hearing loss defined as a Brock greater than 1. And you'll see here the study schema. So again, a randomization 1-to-1 to either get cisplatin alone or cisplatin plus STS or PEDMARK in a 4-cycle course of cisplatin, then a definitive surgeon. This is standard of care for hepatoblastoma. And then 2 subsequent cycles of either cisplatin or cisplatin plus PEDMARK. Next slide. So here are the efficacy outcome of using PEDMARK in combination with cisplatin. You'll see a relative risk of hearing loss by 42% compared with cisplatin alone. This was statistically significant. If you look at those patients that actually had an evaluable hearing exam, then in fact the relative risk of hearing loss was even greater in the PEDMARK arm with a 48% relative risk reduction in hearing loss. So this was statistically significant. It shows a significant reduction in hearing loss. And then importantly, if you look at the bottom left, this is a survival curve, which shows no difference in survival between the two groups, whether you receive cisplatin plus sodium thiosulfate or cisplatin alone. Next slide. These are the safety results from the SIOPOL trial. And importantly, these patients had severe adverse reactions in 40% of patients who received PEDMARK in combination with cisplatin. And what were these? Well, the most common things that we see are vomiting and nausea. Again, this is a highly emetogenic regimen with cisplatin alone. And cisplatin plus PEDMARK resulted in a higher amount of vomiting. Decreased hemoglobin was also noted, but seen again in the cisplatin arm, and then electrolyte disturbances, which is quite common: hypernatremia, hypokalemia, hypophosphatemia, and hypermagnesemia. You'll hear all on the left side. But importantly, in general, these were all grades, but most of these toxicities were grade 1 and 2 with very few grade 3 and grade 4 toxicities. Next slide. So moving on to the second trial that helped push this across the finish line for an FDA approval. This was the Children's Oncology Group ACCL 0431 study. This was a multi-center randomized controlled open label study of PEDMARK in children with solid tumors receiving cisplatin chemo. And this was conducted from 2008 to 2021, again, over a decade of information here. And this was a multi-center randomized controlled open label study of 125 patients, all children from 1 to 18 years old, with solid tumors receiving platinum-based chemotherapy for any stage disease and a variety of different histologies. So versus the SIOPAL trial, which was all standard risk hepatoblastoma, these were basically all comer solid tumors. And we'll get to that in a second. The patients were randomized here 1-to-1 to receive 6 cycles of cisplatin chemotherapy versus cisplatin plus combination with PEDMARK. And the cisplatin doses here were infused over 6 hours or less. The efficacy analysis here was on the intent to treat population, and the major efficacy outcome measure was hearing loss defined by the ASHA criteria, and hearing loss was assessed at baseline and then at 4 weeks after the final dose of cisplatin. I want to point out here, which I mentioned before, the SIOPAL trial was only standard risk hepatoblastoma, but you'll see the variety of different histologies here and also different stages of patients. But you'll see here a variety of different central nervous system tumors like medulloblastoma that made up a little over a quarter of the patients. You'll see a fairly common bone sarcoma, or it's rare, but common in children, osteosarcoma, and germ cell tumor. Those 3 tumors, medulloblastoma, osteosarcoma, and germ cell tumor, made up the bulk of these patients, then followed by neuroblastoma and hepatoblastoma. Next slide. So again, similar to the SIOPAL trial, you'll see a statistically significant reduced relative risk of hearing loss, reported as 25% compared with cisplatin alone. However, if you look at the patients that were evaluable for hearing assessments, now we're looking at the modified intent to treat population of an N of 64. PEDMARK actually demonstrates a 44 and even higher, 44% relative risk reduction in hearing loss versus the cisplatin alone. And if you look at the lower left, this figure here, the Kaplan-Meier, shows no difference in overall survival. And this is in patients with localized disease. And remember the label here that PEDMARK is approved in patients with solid tumors with localized disease. Next slide. Here are safety results from the COG clinical trial, I think mirroring the SIOPAL trial. You will see electrolyte disturbance as the most frequent issue, being hypokalemia, hypophosphatemia, hyponatremia, and hypernatremia, along with stomatitis that seem to be slightly more prevalent in this population of patients versus the cisplatin alone. Other serious adverse reactions in over 5% of patients who receive PEDMARK include febrile neutropenia, decreased neutrophil count, decreased platelet count, decreased white cell count, anemia. We talked about stomatitis, infections, decreased lymphocyte count, and increased ALT. And PEDMARK was permanently discontinued due to an adverse reaction in only 1 patient, and this patient had a grade 2 hypersensitivity reaction. Next slide. So I'm going to summarize here. Cisplatin is a cornerstone therapy for a variety of pediatric cancers. It is not going away anytime soon. The outcomes with cisplatin in our pediatric solid tumors have been exceptional. And because of that, it is going to remain a cornerstone therapy, I think, for at least the next decade or 2 to come. And with that comes the likelihood and the preparation for the most common short and permanent long-term side effects of cisplatin exposure, which includes cisplatin ototoxicity, We reviewed the symptom burden of cisplatin ototoxicity, which is high and permanent, which leads to long-term functional, emotional, social, cognitive, and other problems. We've reviewed data now for PEDMARK, which is the first and only FDA-approved sodium thiosulfate formulation to prevent cisplatin-induced ototoxicity. And this is an important time to emphasize that the Food and Drug Administration here does not permit substitution of PEDMARK with any other sodium thiosulfate formulation. And I cannot emphasize that enough. The two randomized clinical trials that we reviewed, PEDMARK showed a significant reduction in relative risk of hearing loss. That was in both the Children's Oncology Group, a national trial, and the SIOPL international trial in Europe, looking at a standard risk hepatoblastoma. And the common adverse reactions that we see with PEDMARK include electrolyte disturbances, hyponatremia, hypokalemia, hypophosphatemia, hypermagnesemia, as well as nausea, vomiting, pyrexia, and stomatitis. So with that, I'm going to turn it over to Rita Ju, and she's going to go into a little bit more about the ingredients of PEDMARK or sodium thiosulfate.
Thank you so much, Dr. Federman, for such an informative discussion on how to prevent cisplatin ototoxicity, especially with the detailed information about the pivotal trials. So you've just heard Dr. Federman said that generic sodium thiosulfate cannot be used as a substitute for PEDMARK, and the reason why he keeps referring to the brand name of the drug, because most of the time we try to refer to generic name, but in this case, specifically, the FDA has stated that there is no generic substitution for PEDMARK. And that is mainly due to the inactive ingredients in generic sodium thiosulfate that can be problematic, especially in pediatric patients. As a matter of fact, the pediatric healthcare community have learned from a lot of previous experience that numerous inactive ingredients that are common in pharmaceuticals can be problematic when administered to pediatric patients, and especially to neonates. So what I will do now is to walk through some of the important examples of inactive ingredients that you should be aware of, that you should avoid using in pediatric patients. So the first one is a benzyl alcohol. It is a preservative that is commonly used in injectable medications. In adults, it is metabolized to benzoic acid, which is conjugated in the liver and then turned into hippuric acid and then excreted in the urine. However, the conjugation pathway is not mature in neonates and young infants. And for that reason, there has been linkage between benzyl alcohol and gasping baby syndrome in the early 1980s. And this is probably, benzyl alcohol is probably the most widely publicized inactive ingredients that causes side effects to pediatric patients. So what happened is that there were clusters of neonates who were developing what we call gasping baby syndrome. So this is being exhibited by metabolic acidosis, which then resulted in respiratory distress and the baby gasping for air, and that's hence coined as gasping baby syndrome. Associated with the gasping baby syndrome is also some central nervous system dysfunction, such as convulsion, intracranial hemorrhage, hypotension, and then eventually the baby can get into cardiovascular collapse and die. So a fair number of these babies ended up dying, and then there was an association made with this gasping baby syndrome with the use of heparin flushes, large amounts of heparin flushes in the lungs of these babies that contain benzyl alcohol. So the cases that were looked at that was causing gasping baby syndrome were babies that were receiving 99 milligrams per kilo per day or more of benzyl alcohol. Well, nobody know exactly what is the limit of toxicity. There is some association that at least as high as 99 milligrams per kilo per day could cause this problem. So as you've heard, heparin flush is definitely one big source of benzyl alcohol in babies that were used, but other examples of drugs that contains benzyl alcohol that we need to be watching out for is midazolam. And there are some resources that actually recommend that the total daily dose of benzyl alcohol should not be greater than 5 milligrams per kilo per day in pediatric patients. Next slide, please. So the next inactive ingredient I want to discuss is also a preservative. Now, this one is sodium benzoate. And sodium benzoate is also metabolized to benzoic acid that can cause metabolic acidosis that I have talked about earlier. But more importantly, the sodium benzoate displaces the bilirubin from its binding sites. Now, in most of us, bilirubin is bound, and hence it is not, there is very few free bilirubin around. But when you have a substance that displaces bilirubin, then you eventually will have more free bilirubin. And this is especially problematic in the neonatal and the young infant period, is because the blood-brain barrier of these infants were not very developed, and hence these free bilirubin can pass through the blood-brain barrier and cause what we called caniculus in these babies. And caniculus is literally means the staining of some of the brain stems. And this can cause a lot of neurological deficits in babies. And in the worst case scenario, babies can even die from that. We don't know what the critical amount of sodium benzoate it is that will be problematic, but in general, we try to avoid medications that contain sodium benzoate. And a good example is IV caffeine, actually, that is used in the adult population. There's IV caffeine that is used in pediatrics that does not contain sodium benzoate, but the IV caffeine injection that is used for adults for treatment of headache contains a lot of sodium benzoate, and as well as an older example is doxyprem that is usually that is no longer available on the market. Next slide, please. So the next inactive ingredient that we're going to talk about is a solubilizing agent called propylene glycol. It does cause problem. Propylene glycol causes problem in both adults and pediatric patients. However, when you have a smaller pediatric patients, the milligrams per kilo dose could be much higher when the patient is receiving multiple doses of medications contain high amount of propylene glycol. So in this case, high doses of propylene glycol can cause hyperosmolarity, lactic acidosis, and in some cases, hemolysis and hemoglobinuria, as well as neurological disturbances. Again, we don't really know what the critical amount of propylene glycol is, but some medications to look out for with high amount of propylene glycol will include lorazepam and etomidate. Next slide, please. So next is another preservative, thimerosal. Thimerosal is an ethyl mercury that is used mainly as a preservative in some of the vaccines. Now, the concern with thimerosal is the fact that we know that fetal exposure to methyl mercury can cause neurological symptoms. And this is really based on a lot of the studies that were done on fetal exposure of mothers, especially in Japan, eating a lot of fish that contains tuna fish that contains methyl mercury. that resulted in babies having neurological symptoms. Now, one thing to know is that ethyl mercury is slightly different than methyl mercury in that the half-life from ethyl mercury, that is in thimerosal, is a lot shorter. It is an average of 6 days with a range of about 3 to 10 days compared to the 40 to 50 days for methyl mercury. So this really makes the exposure of ethyl mercury in the blood comparatively brief. And it also does not cause as much accumulation, which was what is thought to be causing the neurological sequelae in the babies that are in the fetus that were exposed in utero to methyl mercury. Well, so the one thing to note is that the ethyl mercury concern is really theoretical, but because of the devastating neurological symptoms that can result in exposure to mercury in general, FDA has attempted to eliminate thimerosal from all of the vaccines, and especially in pediatric vaccines. So some states even have legislation to prevent administration of vaccines that contains thimerosal in the pediatric population. So some of the vaccines to note that, especially in the adult formulation that may contain thimerosal is hepatitis B vaccine and influenza vaccine. Next slide, please. So the next inactive ingredient is an interesting one in that it is aluminum, and it is really not as much an intentional additive to pharmaceutical agents. This is because aluminum actually is pretty innocuous around, and it leaches from glass containers. And usually because aluminum is not really absorbed, it is not a concern that you may be ingesting it if there's leaching of aluminum from glass containers. Unfortunately, when aluminum is leached out from glass containers of IV products, then it basically get injected right into the veins and you get into the systemic circulation. An accumulation of aluminum could happen in the bones and the CNS, causing, especially in your very small pediatric patients, when you have a lot of accumulation of aluminum, it can cause bone fractures, and in the worst case scenario, it can cause neurotoxicity. So over 10, 15 years ago, the FDA has come up with a mandate that says that the daily administration, an administration of aluminum has to be less than 5 micrograms per kilo per day. And this is especially a big challenge when you're looking at some of the products that are used to make parenteral nutrition. So some of the examples are potassium phosphate and IV multivitamins that can potentially contain a lot of aluminum. So there's been a series of actions that is for manufacturers to try to use glass that does not leaches out aluminum as much. But unfortunately, part of the problem is we don't usually have the exact amount of aluminum that is contained in these products because the leaching process is slow. And while when you have a manufactured product that it's only been out for a short period of time, you may have very minimal amount of aluminum. And then if the product is sitting on the shelf, it could eventually leach out more aluminum. So what manufacturers are required to do is actually list the highest amount possible of aluminum that they're anticipating to be leaching out in their containers. Next slide. So now the next inactive ingredient in this case is potassium chloride. Now, up until recently, this is not a concern at all as an inactive ingredient in pediatric patients because as far as I'm aware of, none of the products that we use in pediatric patients contain potassium chloride as an inactive ingredient. Now, you've heard Dr. Fetterman briefly talked about the fact that PEDMARK does not contain potassium chloride. we specifically say that is because sodium thiosulfate, generic sodium thiosulfate does contain potassium chloride. And we all know, actually, without me telling you all, that rapid infusion of potassium chloride can cause cardiac conduction disturbances, anywhere from bradycardia all the way to heart block and asystole, and at times ventricular fibrillation and tachycardia as well. So what I have on here on the slide is really an illustration to you how close attention really needs to be brought to this potassium chloride, the amount of potassium chloride that can potentially be infused to a very small pediatric patient over a short period of time using generic sodium thiosulfate. So the first example in here is a 1-month-old that is 4.5 kilograms infant, and the base surface area of this infant is approximately 0.25 meters square. So as you know, that the dosing for PEDMARK for prevention of ototoxicity is in grams per meter square. So in this infant, for a 4.5 kilo infant, the dose of sodium thiosulfate would have been 10 grams per meter square, which is supposed to be infused over 15 minutes. Now, you take a look at the amount of potassium chloride that would be in this dose. It is 44 milligrams, or almost 0.6 mol equivalents. And as you infuse the entire dose of sodium thiosulfate over 15 minutes, this is equivalent to about 0.5 mil equivalents per kilo per hour. Now, note that this is in any references you see on the infusion rate of potassium chloride. This is when you will need to have continuous cardiac monitoring to make sure that you are not causing any cardiac conduction disturbances by the quick infusion. Now, looking at then a 1-year-old, you can see that with a similar calculation, the rate of infusion is as high as almost 0.9 milliequivalents per kilo per hour. Now, this is the rate of infusion that we would, in most hospitals, in most pediatric hospitals, we would only allow to be done in an ICU setting. So you can see that if you don't take into consideration the dose of potassium chloride in this case, you can potentially be infusing sodium thiosulfate in a patient that contains such high doses of potassium chloride in a short period of time and causing cardiac conduction disturbances without monitoring. And you can also, this is also an illustration that because of the doses different, the dosing difference based on the weight of the patient, and also that also changes the amount of potassium chloride. So you can do pretty much a modeling of the dose, the potassium chloride dose that is being infused over these 15 minutes, and see that the older the patient is, the lesser problem. But in the smaller patient, this is a critical issue that really needs to, folks need to pay attention to. And that is the big reason why the FDA have said that you cannot substitute other generic sodium thiosulfate for PEDMARK. Next slide. And finally, just rounding up other inactive ingredients, alcohol is one big one that you really do want to watch out for, because there's items, there are oral and injectable, mostly oral medications that contains a high amount of alcohol, since we do not give pediatric patients alcohol to drink, and some of these cough syrups and all could potentially contain alcohol that is a shot for these pediatric patients. So in general, we want to try to avoid the use of any pharmaceuticals that contains alcohol. And if you can't avoid that, the FDA's dosing is a maximum of 6 milligrams per kilo per day, per dose. And other diseases that you may need to watch out for items like ketogenic, when you have a patient with seizure that requires a ketogenic diet. Carbohydrates become an inactive ingredient in some of these medications that need to be watched out for very closely. And then lastly, celiac diseases, patients, gluten is a big component in some of the medications that we need to watch out for. So with that, that concludes my part of the discussion, and hopefully you can get a sense of why it is important to really take inactive ingredients into consideration as you are administering medication to pediatric patients.
Thank you. So we're just out of time. So I'd like to once again thank Dr. Fetterman and Dr. Zhu for sharing their expertise during this formative educational session. We'd also like to again acknowledge Fennec Pharmaceuticals for sponsoring today's program. And lastly, thank you to all of you for joining us today. So we hope you have a great rest of your day. And this concludes today's webinar.
Thank you.